Welcome to Lunchtime with the Masters, brought to you by PICA. I'm your host, Brett Robotsky, and we have one of the few individuals in this entire profession who needs no introduction, Dr. Harry Goldsmith. Harry is board certified in both boards, has been a leading coder, educator in our profession. So Harry, welcome to Lunchtime with the Masters.
Thank you. Good to be here.
You did such an incredible job stewarding our profession through the ICD-10 issue. I mean, it almost was flawless by the time we got to the end of it. We have all this new stuff coming down the pipe. We have macro, we have MIPS, we have APMs, and probably a half a dozen other initials I can't even pronounce. What's going on, and how are you going to help us get to the finish line?
First of all, I got to correct you. There was at least another one person that helped with ICD-10, I'm sure, out there somewhere. But we did do a good job with that because we started early, and we kept getting delays. That gave us more time.
There's a lot of barometers that they're using, or points of measure of success, but none of those have been validated. Is that posing a problem with all this?
Oh, that is a problem. We were talking about earlier the idea that a patient is not a car where you can take out a part and put in an exact part in there and you're back and running. Everybody's different, so everybody heals differently. We hopefully know the outcome whenever we do an elective surgery, even when we do any kind of reconstructive surgery, any of those things. We know roughly where it's going to go, but a patient can fool you sometimes. And they heal slowly. They get an infection through no fault of you, or it could be the patient.
They order a couple pizzas one night when they're not supposed to.
Yes, and everyone's experienced, please don't walk on this for X amount of time. Use your crutches, and then they come in because their foot's swollen. You go, what happened? They go, well, one time I took off the post-op shoe or the walking boot, just one time, and this is what happened. And obviously, they've been walking on it when you told them not to.
So patients, are they going to have skin in the game if they're not going to get good results or not take good care of themselves?
Well, don't forget macros to give you good results, because you're going to be measured on quality measures that somebody has assured us will definitely make things better.
Like the magazines in your waiting room.
Even though I'm very skeptical of that. But the thing is, the patients will suffer because, personally, I think there'll be a higher attrition rate among physicians when it comes to retirement. I think that what will also happen is that patients will find access a lot harder. And when you were talking about elective surgeries, wow, elective surgeries could be like Canada, where it's way backed up so that, we can get you in with that bunion, but it's going to be like 5 months from now because it's going to be so tough to get them into to see a specialist. Who knows what's going to happen with doctors years from now.
So that has us going forward. But that doesn't mean it's going away. The idea that paying for what you do is going to be drastically different. It's going to be paying for your results.
Well, the bottom line is that they want to get away. They meaning the Medicare definitely, but the insurance industry also wants to get away with fee-for-service, where you reward yourself by adding another procedure or controlling all that. The problem with that is it's extremely expensive. It's hard to control. There's a lot of fraud and abuse. They want to, the payers want to go to a system where it's based on quality, and they may not be paying in a fee-for-service world anymore. They may be going to a capitation arrangement, and that capitation arrangement probably won't go to the individual. That's going to go to a large entity, an ASO, a hospital employment kind of a situation, anything that's big. And what will happen is they'll get the money, and then they divide the money.
So we got to be able to fight and show our worth to get our bigger share of the pie.
Exactly. By the way, it does bother me a lot because we deal with, and I don't disagree with the concept of trying to save money, but I also strongly believe that a provider, with the expenses that they have, really should get paid for what they do. And I'm really, really worried that these charts that they're putting together requiring you to hit certain thresholds literally are artificial. And even the thresholds of quality that they're talking about, many of those things have never been studied, never been proven to change the outcome of the patient. And yet we're implementing that, and we're basing some artificial means in order to make sure that, you get your money.
If we deal with patients, they're supposed to, by the textbook, heal their wound in a certain number of weeks. The problem is we're dealing with patients. They don't listen. The reason they got diabetes, the reason they're 400 pounds is not an accident. Nobody ever accidentally ate anything. They did it by choice. So,
but my question to you as a podiatrist, if one of the measures was, we know that if they lost weight, that would help not just their diabetes, probably their blood pressures, sleep apnea, all kinds of things, their feet, as far as pain in their feet and things like that. The question is, by you advising your own patients about this, how many of those patients then take your advice and literally lose weight?
And hold me accountable for them results seems to be
well, somebody's going to hold you accountable, and it's the people that are signing the checks that you get.
If there's a bunch of doctors in a large community, what can some of those doctors do today to start putting together the data package to show some vendor, choose me over so-and-so?
Well, that's a little tough because the HR programs really aren't set up that way, but I'm sure that they will be starting to capture a lot more data. I know APMA is working with a registry that they're going to put together to capture data that'll be able to be taken out to an insurance company to show them the kind of work that we're doing. So I think that little by little we'll be able to do that. It's going to be interesting to see whether we do that in time or people are just going to be left, hanging there trying to figure out how to maintain their practices.
Well, we're definitely in a transition period, and I think your words are outstanding. Keep your ears open and keep making steps towards progress.
Absolutely.
Well, this has been another exciting episode of Lunchtime with the Masters. Please follow this at the forum. Put in some advice. Go to the forum.podiatricsuccess.com. And thank you, Harry, for joining us.
Thank you.